Thank you very much for the introduction. Sorry for the change in program because I have to catch my flight later and we're a little out of time. So coming from the distal pancreatectomies to the Whipple procedures, and you all know situations like this. You have done a beautiful anastomosis, you feel very happy, and some days later you may face something like that. You don't know what is going wrong. But definitely in this situation, you need a rescue strategy and you need to know what to do with this patient who is probably critical ill by that point of time when the pancreas is completely necrotic, and you have to know how to handle this. You have seen this already, so I can go through this very quickly, the new definition. Please just keep in mind that we only define the grade C fistulas when you have reoperation due to fistula, when you have organ failure due to this fistula, or when you have fistula-associated death. Very easy definition. Only these three criteria are type C fistulas, the really severe fistulas, where you definitely need a rescue, and failure to rescue will result in a very poor outcome. Now, the most important risk factor, all of you know, is the pancreatic fistula for the morbidity and the mortality. Of course, also factors related to the surgeon are important, and also the patient-related factors, which means the histopathological diagnosis, the tissue quality, all these things. This is well known. We all know that in pancreatic cancer, we discussed this in the session before, usually it's no problem to do a good anastomosis, dilated duct, hard pancreas. For example, for the bile duct cancers, this is much more difficult, or for the cystic lesions of the pancreas, because you usually have a more or less healthy pancreas and a very small duct. How to evaluate this? You know, there are a lot of risk scores for that. I think the most established is this one, to predict pancreatic fistula after Whipple procedures. All of these factors are going into this score: the gland texture, the pathology, the duct diameter. Of course, you see the very small ones get a high score, and of course the intraoperative blood loss. When you have long and complicated operations, this is also a risk factor for fistula, and this works quite nicely, which means you have a negligible risk, you have a low risk up to 2 points, and intermediate risk, and once you exceed this, you have a nearly 80 to 100% of risk when you have all the factors that I showed you before. And these are, of course, the pancreas where you can consider taking out the pancreas by the time of the first operation completely. When you feel not comfortable with the anastomosis, you feel that the pancreas is bleeding, that every stitch is difficult, think about taking it out and avoid a type C fistula by this. Now, of course, the big discussion in Whipple is where to put the pancreas. You put the pancreas into the jejunum, or you put the pancreas into the stomach. We have seen only jejunal anastomosis in the last session, so everybody probably does it a little bit like this. You have seen the Heidelberg technique. What is the rationale of that? You may know the RICOPUNK study. This was a randomized study in Germany with 14 centers, 300 patients that were included in that study, comparing the gastric anastomosis and the jejunal anastomosis. And the results were quite disappointing. There was absolutely no difference in the centers who did the jejunal anastomosis and the centers who did the gastric anastomosis. So whatever you know how to do, whatever is your standard, you can do. If you prefer gastric anastomosis, you are fine with this. If you do it every day, if you do jejunal anastomosis, you are fine with that, because the study also very nicely showed that whenever you prefer one type of anastomosis, you do worse with the other type of anastomosis. In all of the centers that participated, this was shown. Now, how can we avoid this? How can we standardize this? There is a position statement of the ISGPS from 2016 recommending some techniques of the anastomosis for the Whipple. And what you see is that the literature was screened, 9 RCTs and 17 meta-analyses on how to do pancreatic anastomosis. And the statement comes out like this: you should prefer a pancreaticoduodenestomy with a duct to mucosa technique. You should not change your strategy in soft glands, or you should not change your strategy in extended resections with portal vein, for example. Preferred suture material, you have seen PDS is recommended here, but of course this is moderate consensus, so everybody takes different suture materials. Also, this was shown in the session before. You might take VLOC, you might take anything else. What about the other things to avoid pancreatic fistula? Stenting might not be very good, but there is a weak recommendation to use a stent in critical pancreata. Somatostatin was already mentioned. In the high-risk pancreas, you should use it. You should not use a double reconstruction. I will show you that later. You should maybe use a drain. I will also come back to that later. You should not use any tissue sealants. This is only expensive and does not help anything regarding the pancreatic fistulas. And when you have a leak and you go in the patient again with surgical, try to control this. You should not try to re-anastomosize the pancreas, not do a new anastomosis. You should only decide either to disconnect the pancreas or to take out the pancreas, but not do a new anastomosis because the first one already didn't work. Why should the second one work in a critical situation? Now, what about the reconstruction? Some people thought if you do a dual loop reconstruction, if you separate the pancreatic anastomosis from the rest of the anastomosis, you might do better. This is shown here. The pancreas is put on a separate loop, and this might have an influence on pancreatic fistulas. However, when you look into the randomized controlled trials, there's absolutely no difference. So the dual loop reconstruction does not offer anything. It just takes longer to reconstruct this because two anastomoses more, of course, and therefore you should not do it because it's not a benefit for the patient from good evidence randomized controlled trials here. I already mentioned the drainages. Maybe you know this study. This was conducted in Dresden and Heidelberg in Germany. We included 400 patients and compared the routine drainage versus no drainage after the Whipple procedure. What was the impact on the pancreatic fistula? And it was quite impressive that you had no impact regarding superiority of drainage placement, but that in the drain group, the pancreatic fistulas were more pronounced than in the no drain group. It was a significant outcome, and also the associated complications with the fistula were higher in the drain group than in the no drain group. So you can, of course, say, I feel better with the drain still, despite results like that. We had these surgeons within the study, and you see these were the crossover patients of the study, where the surgeons had a randomization to no drain, but they said, I don't want that, I exclude this patient, I will put in a drain because I feel better putting in a drain. And even if you do this, you see it doesn't help. Regarding the crossover patients, the no drain group did better than the drain group, and also the fistula-associated complications were less without a drain. So the conclusion from that study is no routine drainage. You should just do it when you have a bad feeling, maybe, but not a routine standard. It's not inferior than if you put a drain anytime. This has already been mentioned. You can measure the drain amylase, of course, and when you have below 5,000, you can take out the drain probably early because 5,000 might be the cutoff for predicting a fistula coming up in the end. So therefore, you should leave the drain in these patients maybe longer. And what is the outcome when you do it? And we do early drain removal in the low-risk patients. This is also a study from Verona. And you see that you have less fistulas, less morbidity, and a shorter hospital stay when you do a timely drain removal in the low-risk patients. What about the high-risk patients when you consider this? This is quite nicely shown here. This is a study from the US. You see this was also a moderate or high-risk pancreatic fistula risk score from 3 to 10, and there was 5,000, the cutoff again on postoperative day 1, and either the patients were scheduled for early drain removal in the low risk or for drain removal at the surgeon's discretion in the high-risk groups. And the results are quite interesting of this study, because in the low-risk group, clinically relevant fistula was 10%. The early drain removal, it was 1.7%. When the surgeons decided in the low-risk pancreata, oh, leave the drain 1 day longer, maybe 2 days longer, these patients did much worse, and the clinically relevant fistulas were 38%. And this is even more than in the high-risk group. This means whenever you leave a drain too long, this is not good for the patient. This will only increase the risk of an infected fistula in the end and maybe a more severe course of the patient. Now, what do we do for a salvage strategy? I think the most important thing you have to remember is you need a radiologist. This is a very old study from the US, and you see 1,000 Whipple operations, interventional radiology in 12% of the patients afterwards, all types of percutaneous or bleeding control. And the interesting thing is this, when you do this, the reoperation rate becomes very low. Remember, if you have no radiologists, all of these patients had a reoperation in prior times. So then only you need reoperations in 4.1% of the patients, and the radiological intervention can control the surgical complications very well. What can the radiologists offer us as a salvage strategy? First of all, of course, they can put a drainage for a collection. This has been mentioned before, and then you can mostly control fistulas. What about bleeding? This is a rather old study from the Netherlands, and I only want to show you this because of the important fact of a sentinel bleeding. Whenever you have a late bleeding due to an erosional fistula eroding the gastroduodenal artery stump, usually all of the patients, or nearly all of the patients, present with a sentinel bleeding before, which means 1 day before the bleeding occurs, they have a little blood in the drain, and then the massive bleeding occurs and the patients are critically ill. So you should not ignore the sentinel bleeding. This is very important, I think. If you have this, I told you the radiologist is the one to contact. You can either do a coiling, shown here. We usually prefer the covered stenting of the gastroduodenal stump in the meantime, because this might also lead to a dislocation of the coils into the hepatic arteries and might cause a problem there. What about the success of this treatment? We have analyzed this in Heidelberg some years ago. You see we had 25 patients with a late bleeding after complicated fistula. We did always a CT and afterwards an angiography, and in most of the patients this was a successful method for locating of the bleeding. Timing of the bleeding was approximately 3 weeks after the Whipple procedure, which means you have an ongoing septic fistula behind, and then after 3 weeks this explodes. Transfusion, 7 units of packed blood rod cells. I think this is quite impressive. The radiologist could help us in nearly all of the patients. Sometimes they needed 2 angiographies for that, but still, despite this, overall mortality was 20%. So complicated fistula leading to bleeding is a really severe complication where you do need a good salvage strategy to save the patient in the end. Whenever the angiography is not successful and the patient is getting unstable in the angiography or in the CT scan, you might consider this so-called REBOA, balloon occlusion of the aorta. The radiologist can just put in a big balloon. He can block this balloon, can block the aorta, and then you have time to take the patient to the OR and try to fix this surgically. However, of course, this is something you need not very often, but the radiologist can help you with this as well when you try to decide doing an angiography and embolization or stenting first, and this doesn't work and the patient is not stable. Coming to the worst management of complicated fistula is, of course, the remnant pancreatectomy. Why is it not our preferred method? Because these are also old data showing that you have a mortality of approximately 40% when you do an emergency pancreatectomy compared to 4 to 5% in elective operations. And this is not only in Heidelberg that this outcome is like that. Also in Hamburg, they investigated this with a remnant pancreatectomy, emergency 20 were performed, mortality 55%. So this is a really kind of dangerous procedure for the patient when you have to decide to go to the OR, take out the pancreas due to the septic fistula or the bleeding. The Dutch colleagues investigated this in the centers in their country, and they had 309 patients with complicated or with clinically relevant fistulas, and then they did a kind of a step-up approach investigation compared to the operative approach going to surgery first. They had an overall mortality in these complicated fistulas of 18%. And when they only put in drains as the first step, this was 14%. When they decided to operate first, this was 36%. I think quite impressive numbers. And you see that all the endpoints were highly significant here, and also the long-term complications after going to surgery first were worse, because then usually you take out the pancreas, you have all the complications of diabetes and all these things. And I think this shows quite nicely the step-up approach, not only for pancreatitis, but only for the management of complicated fistula in the post-operative course might be better than surgery first. What can we do when we decide to operate again? These are the possibilities. You can either disconnect the pancreas and drain it. You can just disconnect it. You can close the remnant. You can disconnect and drain into the jejunum inside. You can take out the pancreas, or you can try to do a new anastomosis. I already mentioned that this is probably not advisable. So what would you decide in this case? I showed you in the beginning. You see this black pancreas. There are 2 possibilities in this situation. Either you can take it out. We did it in this patient, and the pancreas looked like this. So probably this pancreas could have been preserved. We could just have taken out the anastomosis and put in a drain. We did from time to time. You see it's like this. The stenting, external stenting of an emergency disconnected pancreas. This might work when the pancreas is still vital and not necrotic. The other opportunity in this situation, of course, is it looks like this. You have a necrotizing pancreatic remnant, and of course, in this situation, you have to take it out. There's no discussion about this, otherwise you will not save the patient. This has to be taken out, and then you might have the chance that the patient will survive this. So this is an algorithm showing this. The conditions of the operation are important for your management. Either try to keep the remnant if it looks good, or you have to take out the remnant. If it's really complicated, the patient is critically ill, just do this. I will just skip this on the infections and coming back to the topic of my talk.
Please. Yeah, your time is over.
Yes, that's the reason. Just to show you this as the last slide. What about failure to rescue? You see this was an analysis from the US, and you see the very low mortality hospitals and the very high mortality hospitals were compared here for pancreatic resections. The difference in morbidity was 2 times. the difference in mortality was 5 times. And this is exactly what shows you failure to rescue means you might not have very high morbidity, which differs, but your management of the morbidity is important. Otherwise, the morbidity will turn into mortality, and therefore this is what you have to do to rescue the patient and not to end up with failure to rescue, and then, of course, in the end, a high mortality for these complicated fistulas and maybe bleeding of these fistulas. Thanks for the attention.